Postpartum Care Part 1. The postpartum period, also known as the puerperium period, consists of the first 6 weeks following delivery. The uterus is approximately the size of a large grapefruit or softball immediately following delivery. The fundus is midway between the symphysis pubis and umbilicus, and it will rise to the umbilicus within 12 hours following delivery. The fundus descends into the abdominal cavity 1 centimeter or 1 finger breadth per day. By the 14th day, it should not be palpable abdominally, and it should return to its pre-pregnant size by 5 to 6 weeks following delivery. Uterine massage is completed by having the client lay supine with the knees flexed, and you place the non-dominant hand just above the symphysis pubis and then press downward gently. This anchors the uterus. You place the dominant hand around the umbilicus and then begin to massage downward. You locate the top of the fundus and measure by how many finger breadths above or below the umbilicus or at the umbilicus the position of the fundus is. After a massage, then you're going to push toward the vagina to expel any lochia or clots that might have been there. A full bladder can cause that fundus to be high and off to one side, and it can actually cause the uterus to be boggy. Boggy meaning soft. Uterine atony is defined as a lack of muscle tone. When any woman has heavy lochia flow, in other words, heavier than it should be, you always massage the fundus to determine the firmness of the uterus. A boggy or soft uterus will tend to bleed more, and massage will usually help firm up that uterus. Subinvolution is the failure of the uterus to return to a non-pregnant state. Causes of this can be uterine distension by more than one baby, hydramnios, in other words, too much amniotic fluid, or a large fetus, and this can slow down the process of uterine involution. It can lead to postpartum hemorrhage because the uterus will not contract the way it's supposed to. Again, this is the diagram that shows you where the uterus or the fundus should be found postpartum. Intermittent uterine contractions after delivery, similar to menstrual cramps, are called after pains. They are more acute in multiparas due to repeated stretching of those muscle fibers, leading to loss of muscle tone. It is less common in the primipara as the uterus tends to remain contracted, and any woman will experience more after pains if the uterus has been over-distended during the pregnancy. After pains are also increased if breastfeeding is done because it releases oxytocin, and exogenous oxytocic medications such as Pitocin or Methergin will cause after pains. Analgesics are frequently used to help lessen that discomfort. They're usually self-limiting and will begin to disappear rapidly after about 48 hours. Lochia is the vaginal flow following delivery. Days 1 to 3, it's called lochia rubra. It's almost entirely blood, and there can be some mucus in there. Days 4 to 10, it's lochia serosa. There's a decreased amount. It's usually serosanguinous, can be pink or brown tinged. Days 11 to 21, or even up to 6 weeks, it's called lochia alba. It's a white, cream, or light yellow color with, again, decreasing amounts. The total amount of lochia is normally 250 mLs. It's greater immediately following delivery, but it will gradually decrease. To quantify the amount of lochia, we use scant, light, moderate, and heavy. Now, it is normal to have one saturated pad per hour right after delivery, but after a few hours, this does begin to slow down. Scant is defined as less than a 1-inch stain on the pad. Light is a 1 to 4-inch stain on the pad. Moderate is 4 to 6-inch stain on the pad. And heavy is a saturated pad in an hour's time. An excessive saturated peri-pad will be one that's saturated within 15 minutes. There is usually less lochia after a C-section birth because some of the endometrial lining is removed during surgery. It's common to have a heavy lochia flow the first time mom gets out of bed after delivery, or if she's been sleeping for a while, because things tend to gather in the uterus, and then when she stands up, then it comes pouring out. There may be a gush with fundal massage or whenever the uterus contracts, such as when she's breastfeeding. If she is receiving the exogenous oxytocin, the amount is lessened until that drug wears off. She may have some small gushes again with breastfeeding. Continued lochia rubra may indicate that there's some retained placenta. Mom is going to note some clots at times, which should decrease in size and amount. She may note some increased cramping briefly or a change in lochia amount. This should be monitored, but don't get real concerned unless it's frequent, continuous, and large. This slide shows you the way you estimate the amount of lochia. Immediately after childbirth, the cervix is going to be formless, flabby, and wide open enough to admit the entire hand. This allows manual extraction of the placenta and manual examination of the uterus if it's necessary. Following delivery, the cervix can be bruised, or it may even have some small lacerations. By the end of the first week, the cervix will begin to feel firm, and the external os, or opening, is 1 centimeter in diameter. Some edema can be present in the cervix for up to 3 to 4 months, and it will remain slightly open and appear slit-like rather than round. And this picture demonstrates what the cervix looks like following delivery. The vagina following delivery, the walls will appear edematous, and there may be some multiple small lacerations. 3 to 4 weeks after delivery, the vaginal mucosa will heal and the rugae will be regained. 6 to 10 weeks is required for the vagina to complete involution and regain approximate size and contour that it had prior to pregnancy, although it will never regain its nulliparous size. Kegel exercises can help improve this muscle strength of the vagina. Vaginal walls do not regain the thickness until estrogen production is resumed, and it's not well established as long as mom is breastfeeding because she is lactating. Lubrication may be required during sexual intercourse as long as mother is breastfeeding due to decreased levels of estrogen. And she can resume sexual activity when the bleeding does stop. The picture that I have placed here helps demonstrate how tears can happen as mom delivers vaginally. If the baby comes through very forcefully or she pushes for an extended period of time, she can tear down to the rectum and she can tear down through the rectum. When assessing the perineum, we use the acronym RETA. RETA is redness without excessive tenderness. Edema is common, but it's usually fairly mild. Ecchymosis, there can be a few small superficial bruises that are normal. There should be no discharge from the suture line. and the suture line should be well approximated. An episiotomy may have been performed, and that site can take 4 to 6 months to heal completely. And we need to make sure that those sutures are intact. Those sutures will dissolve, however, so mom will find them on her toilet tissue several weeks following delivery. Episiotomy is generally midline or median, so it can go straight back from the lower edge of the introitus toward the anus. Lacerations, again, can also occur during delivery, and in the previous slide you saw pictures. Mom can experience hemorrhoids, perineal trauma, episiotomy, or lacerations, and this can make having a bowel movement difficult. It is best observed if she is side-lying or in a lithotomy position. If the hemorrhoids were present during the pregnancy, they can be worse following vaginal delivery. Interventions for the perineum. We need to make sure that we educate mom on how to cleanse, which is using warm water and then patting dry, basically staying clean. Ice packs, sitz baths, perineal care, topical anesthetic, cooling astringent pads like the Tux pads, and ordered analgesics. With the Tux pads, these are analgesic and they can help numb the area, but they have to be left in place up against the suture line. And the acronym for evaluating an episiotomy. Both nursing and non-nursing mothers will experience breast changes following delivery. The colostrum is the initial milk that is produced from the breast. It contains antibodies and it's very high in nutrients and calories. Now, if you look at the picture of the milk on the left, that is colostrum. It's yellow. It's often called liquid gold because it is so amazing in the quality, even though there's not much quantity. Prolactin is released following delivery, and it's the hormone that will initiate milk production within 2 to 3 days of delivery, and it's continued by the suckling of the infant and the removal of the milk from the breast. The breasts will become full and heavy and possibly even tender. Oxytocin is the hormone that is necessary for the letdown or the ejection of the milk from the breast. There's mature milk will be the next type of milk that is produced by the mother's body, and the nutrients in this mature milk are adjusted as to the infant's needs. Now, within the mature milk, we have the foremilk, which is the milk that is released to start with, and then we have the hind milk. The foremilk will satisfy the baby's thirst, but the hind milk is what satisfies the hunger because it has a higher fat count. As nurses, we need to assess mom's nipples for the first few days of breastfeeding for trauma. There may be redness, blisters, or fissures. Interventions for these sore nipples will include positioning the infant at the breast so that enough of the areola is in the mouth, because we don't want the nipple to be compressed between the gums. That will only make mom even more sore. She needs to try and avoid engorgement between feedings. Vary the position of the baby. Don't use soap on the nipples. Use breast pads for leaking milk. And rub expressed milk into the areola and allow it to air dry. Now, engorgement can occur despite all measures taken. And engorgement is just what it sounds like. The breast gets very full and very hard and very tender and very sore. Interventions can include frequent feedings every 2 to 3 hours, ice packs, expressing small amounts of milk, which you don't want to express too much because the body replaces everything that's removed, Tylenol or ibuprofen, and cabbage leaves. Non-breastfeeding mothers, they can have some tenderness 2 to 3 days following delivery. They do still have colostrum. The discomfort usually will decrease within 24 to 36 hours following onset, and some of those non-breastfeeding mothers will still experience some level of engorgement. Remember, the placenta is also part of the endocrine system. Excuse me. So when the placenta is expulsed, there's a decrease in chorionic somatomammotropin. There's a decrease in estrogen, cortisol, and insulinase because the body no longer requires so much insulin. A decreased estrogen level will result in breast engorgement and help mom begin to diurese all of that extra fluid. The estrogen levels will begin to increase by 2 weeks after delivery in women who are not breastfeeding. There's also a decrease in progesterone and a decrease in the human chorionic gonadotropin, or HCG. Pituitary hormones and ovarian function, again, lactating and non-lactating women vary greatly. The prolactin levels are going to remain elevated in women that are breastfeeding. And menstrual flow. Dependent on breastfeeding, the length, frequency, and duration of each feeding, etc., will help determine when that first menstrual cycle will start again. Usually it will be at least 6 months if mom is breastfeeding regularly. In non-lactating women, ovulation is usually 27 to 75 days, with 4 to 6 weeks average following delivery. Now, ovulation can occur anytime following birth with or without menstrual bleeding, so women need to be very cautious about about resuming sexual activity without any type of birth control. The first cycle following delivery is usually heavier, and it will regulate after 3 to 4 cycles. If you've ever been pregnant, you know that following delivery you still look pregnant for at least a couple of weeks. About 6 weeks after delivery, mom's abdomen will return to near pre-pregnancy size if it's going to. The muscle tone is going to be dependent on the previous tone, and overdistension over the uterus can slow down that muscle tone return. Diastasis recti abdominis is the separation of the abdominal wall. And if you look at the picture on the bottom, you can see that separation of the abdominal wall. It does become less apparent with time. The pre-pregnant urinary system. There is an increased risk for infections due to a dilated urinary tract. The urine components will gradually return to non-pregnant components by 2 to 3 months post-delivery. And postpartum diuresis. Remember, there's a lot of excess fluids circulating through mom's system, and that fluid is released post-delivery, and it can take 2 to 3 days. Mom may have up to 3,000 mLs per day that she is diuresing out. Profuse diaphoresis will also be excreted, and that helps get rid of some of that excess tissue fluid. With the urethra and bladder, there is an incomplete emptying of the bladder postpartum that can lead to an increased risk for hemorrhage and/or UTIs. Mom may experience a decreased urge to void. Excuse me, and that voiding reflex can be affected by trauma or an episiotomy. A distended bladder, again, can lead to increased lochia. The tone usually is restored within 5 to 7 days post-delivery. Mom's appetite. Most new mothers are usually very hungry. Spontaneous bowel evacuation may not occur for 2 to 3 days following delivery, and operative procedures can lead to anal incontinence. And mothers are also at an increased constipation risk. Hemorrhoids can develop during pushing or straining with stools. The neurological pregnancy discomforts will usually disappear following delivery. Some women experience numbness and tingling of the hands and fingers. It affects about 5% of women during pregnancy. And again, this disappears after delivery. But lifting and carrying an infant can actually aggravate that condition. Any postpartum headaches causes need to be investigated. It can be possible postpartum onset preeclampsia, can be due to stress, or it might even be due to leakage of cerebrospinal fluid if mom had an epidural or spinal anesthesia. The cardiovascular system. Women will tolerate blood loss well during delivery because they have that increased blood volume during pregnancy. The average blood loss during a vaginal delivery is 300 to 500 mLs. The average blood loss during a cesarean delivery is 500 to 1,000 mLs. Blood volume will decrease by about 16% following delivery. And realize then that because they have this blood loss, that orthostatic hypotension is very common following delivery. It's why we don't want women out of bed without faculty or staff assistance the first time. Cardiac output will remain increased following delivery for about 48 hours. Then by 6 to 12 weeks postpartum, it should return to pre-pregnant levels. Vital signs will return to pre-pregnant levels within a few days following delivery. And as far as blood components, women are prone to clot formation during pregnancy and in initial postpartum periods. The red blood cells increase after about 8 weeks. White blood cells are normally increased following delivery, and this can mask infections. And varicosities, this does include hemorrhoids, are usually totally or nearly completely regressed following a few days following delivery. And musculoskeletal, the joints that have been loosened during the pregnancy to expand slightly to allow passage of the fetus begin to stabilize 6 to 8 weeks after delivery. Although the feet joints can remain separated, and the new mother may note an increased shoe size after pregnancy. Very common to have a larger foot after having a baby. Integumentary, mom may have had the cloasma, will usually disappear by the end of pregnancy. The hyperpigmentation may not regress completely. Stretch marks will fade, but they never seem to disappear. Vascular abnormalities. The angiomas will regress, but the spider nevi may persist. Hair growth will slow, and the fingernails will return to the pre-pregnant consistency and strength. As far as immunity, there's no significant changes. But if the client was not immune to rubella, the vaccine is administered in the immediate postpartum period or as soon as possible. RhoGAM is administered within 72 hours postpartum to Rh-negative mothers who have an Rh-positive newborn.